Hi, I'm Ralph Ruban, the Baxley Professor and Director of the Department of Pathology here in the Mario Molina Studios at Johns Hopkins, where we celebrate Johns Hopkins and the history of Johns Hopkins. One of my proudest moments at Johns Hopkins is the response of the faculty, the staff, the students, and the trainees to the COVID-19 pandemic. And so it's only appropriate. I'm really happy that today we have Dr. Brian Garibaldi here joining us, who helped lead the Hopkins response to the pandemic. Brian, welcome.
Thanks so much for having me today.
Great. Brian, is there anything in your training or your experience that would have prepared you for the COVID-19 pandemic?
So back in 2014, when there was a large Ebola outbreak in West Africa, we brought together a team here at Johns Hopkins to think about how we would care for an Ebola patient that came to Johns Hopkins. And that led to us creating a biocontainment unit, which is not just a physical space in the hospital, but also a team of multidisciplinary providers from across the campus who have been training for many, many years to care for patients with high consequence pathogens. And when we built that unit, we knew at the time that the risk was something like Ebola, which is spread through contact with bodily fluids, but we were also preparing for something like a respiratory virus. And so after we built that unit, we became one of 13 federally funded biocontainment units across the country who had been training for years to try to not just prepare for the first patients, but also help hospitals and health systems and communities get ready for a new virus outbreak.
Brian, how big was that, the containment unit? How many patients could it handle?
Yeah, so we only had 4 beds because initially the ask from the government was to be able to take care of up to 2 patients with a viral hemorrhagic fever like Ebola. And then we partnered with a sister unit where we had another 10 airborne beds that we could take care of patients with airborne related diseases. So obviously that was not enough for COVID, but we knew that it would be sort of the first line to start caring for patients and suspected cases as the rest of the health system would have to ramp up and build capacity.
What were your thoughts when you heard about that first case in Wuhan, China?
So, at first we didn't know how serious it was going to be, but we were obviously very, very concerned. The reports coming out of Wuhan that started trickling in over social media, but then became sort of official reports from the WHO suggested that what was happening was new, it was different, and it was a severe respiratory virus. So I think we're all very concerned about, number one, would this come to the U.S.? And if it came to the U.S., how would we ramp up capacity to deal with, the numbers of infections that we might see? I mean, Wuhan had thousands and thousands of infections, and across our biocontainment unit network, we only had about 50 beds in the country, right? So we clearly didn't have enough capacity just among those units.
And then the virus hits Hopkins. What were your thoughts that day that the first patient was admitted to Hopkins with SARS-CoV-2?
So, our first suspected case actually happened when I was at a conference out in California. So I remember just running to the airport, getting on the first flight back, and just heading straight to the hospital where we then brought the patient from one of our intensive care units over to the biocontainment unit. And I remember, we were obviously, there was a mixture of excitement because, there's a lot of energy that goes into activating our biocontainment unit, and we have just one of the most amazing teams I've ever been a part of. So there's that energy about, hey, we're going to activate, we're going to put into practice what we've been training for. There's obviously a lot of concern, right? We didn't know a lot about this virus. We knew that it was likely respiratory, but we didn't know how transmissible it was. We were confident in our training and in our gear, but there was still that uncertainty of did we have enough? Were our protocols, would they hold up? Would we stay safe? Would our staff stay safe? Would our families be safe? So I think there was a lot of excitement, but that was mixed with, I think, concern.
And so what was the status of clinical care when that first patient came? What was known? What did you have to offer the patients?
Yeah, so when we had our first confirmed case, and I remember this really clearly, he was a young man who was really fit. He did marathons and he weight trained, and he was in much better shape than I am or any of our staff. And I remember thinking, oh my gosh, if this gentleman could be this sick from this virus, what is going to happen to the rest of us if this continues to spread? And right around that time, there were reports about hydroxychloroquine being used in France in combination with azithromycin to try to treat COVID. And so that was something people were thinking about. There were case reports of using corticosteroids in China, potentially to reduce inflammation. But up until that point, we'd always been really worried about using steroids in a viral infection. There's lots of talk about using anticoagulation because there are autopsy studies from China showing lots of blood clots everywhere, and not just big blood clots that you can see with imaging, but micro blood clots throughout different organs, particularly the lungs and maybe even the kidneys. We really were flying blind. The other thing that we didn't know was that we really didn't know what was the role of mechanical ventilation. How quickly should we put patients on mechanical ventilation? How long would it take for our anesthesiology and pulmonary colleagues to get into the room, to get into their gear, and to safely put someone on a breathing machine? And so there really was a lot of uncertainty, and we put together just an incredible multidisciplinary group across the institution to talk about what is the evidence, what is out there, what are we seeing clinically with our first patients, and what do we think would be a reasonable protocol to put together for our patients at Hopkins, not just to take care of those patients, but also to begin to gather information to inform other people, how do you take care of COVID patients?
And so it's amazing. What were the challenges you then faced in bringing on new protocols? I imagine there's trying to pick the right one, and then supply chain shortages and all these things. You had to bring them all together. Can you describe that process in greater detail?
So, early on, we knew that we wanted to engage in clinical studies of what was happening, but we also knew that we had so few patients up front that, we couldn't use that experience to definitively know if what we were doing was correct. So I think we got together a group of critical care physicians, anesthesiologists, pulmonologists, infectious disease doctors, and talked about, what should our standard approach be to managing these patients on the ventilator? And we're blessed here at Hopkins to really be one of the homes of understanding acute respiratory distress syndrome and ARDS, which is what COVID caused. And so we had some of the leaders of the ARDS network, which became the PEDAL network, like Roy Brower, helping us to understand, like, hey, this is a new disease, but maybe it's not so different from the other things that we see that cause lung injury. And so let's go with what we know in terms of how to manage this. And that really informed our ventilator protocols. Medication protocols took a little bit longer to really, become well formulated and to be informed by data. But up front, I will say, we did give a few patients hydroxychloroquine when it seemed that maybe there was a benefit, and it's a medicine that we had used in the past for a number of other diseases, and it had a known side effect profile which seemed to be acceptable. So we did use that early on until the evidence showed that it didn't work. I think it took a little bit longer for us to embrace using corticosteroids just because of our prior experience not seeing clear benefits in other forms of lung injury prior to the COVID epidemic. So I think that took a little bit of time before we really had our feet underneath us to say, hey, we're going to give patients dexamethasone if they're on oxygen. We're going to use remdesivir once it became available to be able to treat the virus itself. And then we're going to have a standardized approach to mechanical ventilation.
The one thing, at least reading the lay press, the ventilating patients in the prone position seemed to make a huge difference. Can you describe that when the evidence was strong enough to do that, and was it in fact such a game changer?
Yeah. So, whenever someone has low oxygen levels or hypoxia, a lot of times when you're lying on your back, the back part of the lungs are either involved with inflammation or they become a little bit collapsed from lying on your back. And so we've known for many years in patients who are on a mechanical ventilator with acute lung injury, if you put them on their belly, their oxygen levels will get better. And in certain cases, their outcomes will be better. And so for the mechanically ventilated patients, we were using proning very, very early on because we knew from prior experience that it worked. What was a little bit less clear was what would happen if you took an awake patient who was not yet on a breathing machine. If you turned them over, what would happen to their oxygen levels? And so there were some preliminary studies that were done that showed their oxygen levels would get better. But I will say in practice, sometimes it was hard to get patients to do that because it's uncomfortable to lie on your belly when you're short of breath. With all the things that we do in the hospital, it's hard to keep someone on their belly and still be able to provide them medications and to do assessments. So I don't think the evidence ever really came out that in the awake patient not on a breathing machine, that proning or putting them on their belly actually led to improved outcomes. Once they were on the ventilator, we definitely used it, and I know that it saved people's lives.
And I love these technical advances, of course, but we're also human beings. Can you describe your feelings and the feelings of the staff and those around you? On one hand, you're in the trenches saving lives. On the other hand, you're exposing yourself to a potentially deadly virus that you may take home, and you're seeing all this suffering at the same time.
Yeah. So at the very beginning, obviously there was this mixture of fear and excitement that we talked about. And, I remember, walking into the room for the first time, putting on my first PAPR and going into our first confirmed patient's room thinking, okay, I think we're ready. We're going to do this, and we're going to do it well, and we're going to hopefully be a model for everyone else for how to do this at our institution. But at the same time, we were all very concerned that, my biggest concern was, what if one of our staff members became ill? As someone who helped design our protocols in our unit and put together the team, I was really concerned that one of our staff members would become ill. I also remember thinking, well, maybe, is it safe for me to go home right now? Our team at the very beginning, there was only a handful of us who were taking care of these patients. And so I'll be very honest, I moved into the hotel across the street from the hospital for about 2 weeks. And I sent my wife and kids out of Baltimore to stay with her brother, just so that I knew that they would be in a place where they could isolate, and then I could focus on the task at hand. At the same time, I think there was this incredible sense of not just excitement, but also responsibility. We were the first people at Hopkins to be caring for these patients, and we recognize that this is a new disease that no one's seen before, and the observations that we make and the way that we communicate those observations to others might actually lead to some change or some impact that would benefit not just our patients, but the thousands and millions of patients who came after. And so I do think we felt this sense of responsibility, but also privilege, right? I mean, how many times in your career do you come across a disease that didn't exist when you started training? And I hope that we never encounter that experience again, but I think at the time we recognized that this is a tremendous responsibility, but also a privilege to be able to be among the first providers here to take care of those patients.
Well, thank you for your efforts, certainly. In a number of your answers, you've alluded to the importance and the value of teamwork. Can you describe in greater detail the teamwork at Hopkins, and how did the team function and get together?
So, the teamwork here, existed and was amazing before COVID, and really led to the preparations that allowed us to take care of patients. And that starts with every person who has anything to do with the infrastructure of this hospital. It's the doctors, it's the nurses, it's the respiratory therapists, the pharmacists, the technologists in the lab, the folks who help us prepare and clean the rooms, the people who do the food service, supply chain, you name it. Every part of this hospital or university that is involved in taking care of any patient was brought to bear onto COVID. And so starting in January of 2020, when we established an incident command team, every aspect of that university was put into place to figure out, all right, who's going to care for the first patients physically in the room, but who's going to support every other aspect of those operations. And, it was just amazing to see how many people were, involved in the care of those first patients, and also how we rotated staff. When we shut down the operating rooms, for example, we had our operating room technicians and nurses coming to be safety officers on our COVID units who were telling us and keeping us safe, making sure that we're putting on the right gear, checking our PAPR batteries, taking off the gear in the right way. I mean, everyone was involved in this, and it's unbelievable. And yeah, I remember one of my favorite memories of COVID was Christmas Eve of 2021, or sorry, Christmas Eve of 2020, when we activated another COVID unit and we had turned our ICU back into a COVID unit. And I remember everyone was really sad about the fact that we were back on, in full protective gear the entire time, and the whole unit was isolated. But that morning we banded together and said, you know what? We're going to sing holiday songs at every patient room. And we're going to let the patient, if they're able to communicate with us, tell us what holiday song they want to hear. And if the patient can't participate, we're going to ask their nurse, what do they think the patient might want to hear? And if they didn't know, then what do you want to hear? And we rounded that day, and every patient we started with singing a Christmas or a holiday song. And I think that really sort of encapsulated the teamwork and the camaraderie, and how close you get to people when you're in these situations of uncertainty where you're really depending on each other to keep each other safe and to try to make sure we do the right thing for our patients.
Beautiful, beautiful. Now, you've described it, it was not linear in that things progressively got better, but they would get better and then there'd be another variant coming. How did you and how did the team maintain the effort through those. It must have been
Yeah.
very discouraging to think, oh, we're finally through it, and then comes Delta or Omicron.
Yeah. Well, I think we were blessed here, particularly on the physician side, to have such a deep bench, right? So being an academic center, we have lots of folks who are not 100% clinical. They spend a lot of their time doing other jobs, either in, health policy, basic science research, clinical research. And so we were able to rotate staff among the physician providers to make sure that people were getting breaks after we went through the first several months of the pandemic. I think we had a really hard time. Our nursing staff really bore the brunt of a lot of, I think, the burnout that happened, because we didn't have as deep of a bench in terms of rotating people out. There was already nursing shortages before the pandemic started. And obviously we were asking our nurses to go above and beyond, in some cases taking care of patients who were sicker than the patients they would normally see. And so the hospital really tried through their incident command center and through operations to try to rotate which units would then be activated again for COVID patients based on how long the unit had been activated before, what their staffing levels were like, and actually, checking in with the people on those units and trying to understand, okay, this unit had a really, really rough month the last time they were a COVID unit. Let's see if we can shift the COVID patients to another unit this time around and give them a little bit of a break. I hope we did a good job, but I know that people were really tired and really burned out. And unfortunately, a lot of staff, not just at Hopkins, but throughout healthcare, have moved away from healthcare because of how difficult it was.
Insane. Now, can you kind of in broad strokes describe, and you've described a couple of them, the major advances in care that you've seen over these last couple of years?
Sure. So there are a number of advances, and these are not going to be in any order of particular importance. They're all important. I think vaccines obviously were incredible. The fact that, from the first case we had at Hopkins in March of 2020 to having our first staff get vaccinated right before Christmas of 2020, that was incredible. And I just remember the relief that staff would have coming back. I got my shot on Christmas Eve when I was working in the COVID unit. I remember going back to the unit and everyone was just hugging each other and giving high fives, because there was a sense that we still need to be careful and vigilant, but now we have a little bit of extra protection, and now we have a little bit of extra breathing room to be able to take care of patients and hopefully reduce the number of patients that we're going to be seeing. So vaccines were phenomenal. Monoclonal antibodies were really important in reducing the number of high-risk patients who ended up having to come into the hospital with severe COVID. Antivirals like remdesivir early on, I think, were really important in reducing the progression to severe disease and hopefully getting patients out of the hospital sooner. Having an oral antiviral, now having a couple that are available on the market, is a game changer, right? Because people can get access to them much more quickly. They don't have to go to the hospital to get them. They don't have to have an IV to get an infusion like a monoclonal antibody or remdesivir. And we know that has saved lives. Steroids, a medicine that we use all the time for other diseases, and that's really accessible and really inexpensive, have also been really helpful, particularly in patients who present already requiring oxygen. Steroids help reduce the likelihood that those patients are going to end up in the intensive care unit or on a breathing machine. But I also think it's the workflows that we've created. Here at Hopkins, we are unbelievably blessed with such a talented facilities department, clinical engineering, infection control and prevention. They were able to build airborne units in a matter of hours. And they also had the foresight when we redid some of our clinical buildings, about a decade ago. All of the floors in one of those buildings can become an airborne isolation unit. So we were able to ramp up COVID units very, very quickly, and then create protocols to train new providers really, really quickly. So while we were caring for the first patients in the biocontainment unit, our biocontainment unit team and hospital epidemiology and infection control trained hundreds of providers, close to 600, in how to put on COVID gear and safely take it off. And then they created a safety officer program so we could train other people to then become stewards of each unit and say, hey, we're going to help everyone on this floor be safe from anyone who needs to enter this unit. No matter what their job is, we can keep them safe. And so I think those protocols were probably as important in keeping our providers and our staff safe during the pandemic.
Now, we have a tripartite mission: research, teaching, patient care. And as this is going and you're facing an unknown virus, can you describe some of the research efforts that were here in Hopkins to help fight this virus.
Sure. And I hesitate to describe specific ones because that means I'm going to forget to talk about every single one that was important. Very early on, Anthony Rosen, who's our Vice Dean of Research, he called me, and I remember getting this call on the COVID unit, on the BCU, and he said, we need to put together a group of folks who are interested in doing research on COVID, and we need your team who is seeing the first patients to be a part of this group to tell us, what are you seeing, what are the clinical questions that you have, and how can our research inform clinical care? And so we put together, initially it was 3 times a week, we had these meetings where it was people from all across the university, Nobel laureates, Lasker Award winners, people who are in the trenches doing cutting-edge research, asking us lots of questions about what are you seeing, what might it mean, and what can we do to help? And I remember during one of these meetings, Anthony Rosen said to me, well, what's the association or what's the relationship between having a particular lab test that's elevated, something called a D-dimer, and the likelihood that someone's going to go on a breathing machine? And I remember saying to him in 2 consecutive meetings, well, I can't keep all of that in my head right now. I'm seeing too many, there's too much going on. And he's like, well, you shouldn't have to. We should have an army of biostatisticians, and we should have a data registry, and we should be able to answer these questions in near real time. And so true to his word, that weekend, Anthony created a registry that we call the Crown Registry, which I've helped to direct with him. And we now have over 15,000 inpatients who are cared for at the Johns Hopkins Health System across our 6 hospitals. We have hundreds of thousands of outpatients who tested positive for COVID. And we've been able to use that registry to design real-time prediction models that were actually being used during some of our surges to inform which patients might require ICU level care, which patients need a little bit closer monitoring or closer follow-up. We've looked at the comparative effectiveness of different therapies. So we were using a medicine called tocilizumab, which is an anti-IL-6 medicine that combats inflammation, based on our data showing that it actually helped reduce the likelihood of mortality. We were using that medicine 6 months before the clinical trials came out, saying that this definitely has a benefit and we should think about using it. We've also been able to use that registry to look at disparities in healthcare. So for example, we have thousands of patients who had gotten a blood gas analysis where we directly measure their blood oxygen levels. And we could compare that to a pulse oximeter, which is a non-invasive way of measuring oxygen. And we were able to show that the pulse oximeter systematically underestimates hypoxemia in African-American patients. And that's led to an emergency meeting at the FDA, and is hopefully going to inform changes in the technology that we use, not just for COVID, but for almost anyone who comes into a physician's office or to a hospital. And so that was the data registry side of things. But at the same time, there was a biorepository that was set up called SEPSI, where people were able to look at biomarkers and blood and urine and learn about what's happening to the kidneys and the hearts and the lungs of patients in real time. And we're able to publish things about acute kidney injury in COVID, acute myocardial infarction in COVID. And that's not to mention the actual clinical trials that were done looking at a whole host of different medications. Some were part of a large national study like the ACT trial, which showed that remdesivir led to a clinical improvement. Our biocontainment unit team, led by Noreen Hines, was the Hopkins arm of that study. But many investigators stepped up and did small trials, proof of concept, that then went on to actually be medicines that we're now using in COVID. So it was an entire university enterprise-wide effort to do research.
I guess it's a great example of what makes Hopkins so special is it's not research or patient care, but rather the patient care informing the research questions that are asked, and then the research in turn helping to change patient care.
And those meetings that we had, and they continued for 2 straight years, they're among my most enjoyable moments during COVID. Just hearing the way that other folks were thinking about the problems that we were facing and the creative solutions that people came up with during those meetings. It ended up, a lot of it informing research, but much of that went towards informing some clinical care, clinical protocols. Utilization of scarce resources was a big topic that came up with those meetings. It was just an unbelievable group of people who worked on COVID tirelessly.
And so you beautifully described the clinical need and the research and the advances. When did things kind of stabilize and you could take a deep breath and relax, or have they not stabilized yet?
Well, thankfully, even though COVID is still happening right now, we have not seen the number of patients in the hospital during some of the surges we saw with Delta and Omicron. And we have not seen in the intensive care unit a lot of COVID patients. You know, I've seen in the last 6 months, maybe 2 patients with COVID who have come to our medical ICU. So I think from a clinical standpoint in the hospital, things have started to get back to closer to where they were before. But I hope they don't get back to normal, right? Because during COVID, the collaboration across departments and across units was so incredible. I remember one of my ICU months, my team was myself, a pediatric cardiologist, and a neurologist. And, you know, when do we ever, you know, we obviously share patients sometimes and consult, you know, for each other, but working together side by side, I learned so much that I'm actually using and carrying forward in my practice now from working with those multidisciplinary providers. I hope it doesn't get back to normal. I hope we continue to have those cross ICU collaborations and those cross unit collaborations that made us take care of COVID patients better, but I think is going to help us take care of all the patients we see.
Fantastic. Now, thinking back, what's your proudest moment? The thing you're most proud of, if you could, I know it's hard to name one, there are probably many.
So, you know, I'm so proud of the Biocontainment Unit team. You know, from the moment that we activated our Incident Command Center to the night in February of 2020 when we made the decision we're going to activate the Biocontainment Unit, they have just been such unbelievable stewards of infection prevention, critical care, patient safety, and staff safety. And they've become, you know, models for the rest of the hospital. You know, not just the work they did on the Biocontainment Unit, but the work they did to help set up all of the other units throughout the hospital, to set up the transport protocols that transported thousands of COVID patients, not just within Hopkins, but from other hospitals to get, you know, the advanced care that our ICU teams could provide. And, you know, I think for me personally, a direct reflection of that is when I was asked to help care for the president when he developed COVID. I was asked to be a part of his care team, first at the White House and then at Walter Reed. And that really is a reflection of the work that not just the Biocontainment Unit did, but Johns Hopkins did. You know, the work of the Coronavirus Resource Center being the source of information for people who wanted to understand the pandemic. All of those things converged on the White House recognizing that they wanted to have folks from the best institution in the world who really is at the cutting edge of COVID help out. You know, for me, that was just a reflection of that. I'm really proud that we were asked to be a part of that.
Right. We're proud of you too. But I guess in thinking about the Biocontainment Unit, then the lessons learned also now help with new issues, the monkeypox coming forward and things. So now Hopkins is then presumably well prepared for the next unanticipated pandemic.
Well, I think we're better prepared. And I do think having had a Biocontainment Unit really helped us pivot quickly to an all hands on deck approach, because we were able to take care of the first 3 or so weeks of patients while the rest of the health system was able to ramp up. But our work is not done, right? You know, we've seen a number of outbreaks recently in Africa in particular, things like Marburg virus, Ebola Sudan virus, Lassa fever. You know, there are emerging outbreaks that are happening. And there certainly is a risk that there's going to be another respiratory viral outbreak. I think we continue to maintain the preparedness levels we have here and the cross collaboration that allows our incident command team and emergency management teams to pivot to whatever the new crisis might be. I hope that as a country, we take a hard look at the lessons that we've learned, and that this isn't just a 5-year blip where everyone's excited about preparing for pandemics and then we kind of relax and forget about it for a while, and then, you know, we get blindsided 10 years from now. I don't think that will happen here, but I do worry about our ability to sustain that level of readiness throughout the country, and that's what we're really working on now with our national partners.
Great. So we've talked about your proudest moment. What about your most fearful moment, the moment you were most afraid?
So one might be a funny moment. The second night after we started caring for our first confirmed patient, we all had thermometers and we were taking our temperature. And I couldn't find the hospital-issued thermometer. And so I grabbed one that's just out of the drawer in the bathroom, and my temperature was 103. And I was tired. I didn't feel bad. I was like, uh-oh, like, I think I might have COVID. And so, you know, I called my wife. She's like, just take a deep breath, take your temperature again. It was 102. So I waited like 10 minutes, and then I took my temperature again, and it was 96. And I took it again, and it was 98. And it turns out the thermometer was just not a good thermometer. So that was sort of a personal, scare early on. But I do think it was when we had our first intubated patient. And very quickly, we had 3 intubated patients. And then 3 weeks in, we had the entire intensive care unit. We had 24 intubated. We have a 24-bed unit. And on any given day, you might have, before the pandemic, maybe 4 or 5 patients who were really sick on a ventilator, who had lung injury. There was one day when I walked in and we had 24 patients. They were all intubated. They were all paralyzed. They were all deeply sedated. And they were all on their belly because that's how severe their lung injury was. And I remember turning to one of my colleagues and said, we can't sustain this. And I think that was probably the most scared I was, recognizing the magnitude of what we were facing when even our ICU, which is among the most equipped and best staffed in the world, we knew that we had hit our limit. And very quickly we had 6 ICUs that were taking care of COVID patients. I think that was the most scared I was.
That you guys rose beautifully to the challenge. That's wonderful. I remember the day the Air Force flew the jets over the hospital. Was that hokey, or did it have meaning to the group?
Yeah, those things really did matter. The first couple of weeks, I remember when we activated our the MICU became sort of the main COVID ICU for a brief period of time until we opened up lots of other ICUs. You could look across Orleans Street and see people on the Orleans parking garage with signs saying thank you. And every restaurant in Baltimore was sending us free food for lunch because they were closed, but they were still making food because they had food. And so that meant a lot because we knew that this was going to be all hands on deck. We knew that everyone's life was going to be impacted by this, not just people who work in the hospital. And to see those people recognize that, knowing that they were going to have to deal with this very, very soon, but putting aside those concerns and recognizing the folks who are working on the front lines, that meant a lot to us. And so gestures like, having the Air Force jets fly overhead to acknowledge the work that everyone was doing, I think that matters.
Yeah, fantastic. Are there any questions that I haven't asked you that you'd like to let us know about?
Yeah, I would just say that, I've mentioned a lot of different initiatives and a lot of different people, but I haven't been able to mention all the incredible work that's happened here at Hopkins. And, it's just, we knew going in that we worked at an incredible place and that we were very, very lucky to be a part of healthcare here. But I think the pandemic really showed that this place is truly exceptional, really rose to the challenge. And I'm so proud to be a part of the Hopkins family. And I really think we are a family. And I think COVID brought us closer together because of the work that we did together as a family.
Well, you are truly exceptional and a wonderful part of the Hopkins family. So thank you so much for taking the time to meet with us today. We really appreciate it.
Well, thank you, Ralph. And thank you to everyone who's watching for what you guys did during the pandemic.
Okay. Thanks.